In this video, we will do an exam review of cavernous sinus thrombosis for those who are ready to take the exam. First, few important exam questions, and then we'll do the topic and get the answers after the topic is done. Question number 1. Which part of facial infection most commonly causes cavernous sinus thrombosis? Number 2. Which infections cause cavernous sinus thrombosis? Number 3. Which infection causes rapidly developing blindness? Number 4. Where is cavernous sinus? Number 5. In which direction does blood flows in the sinuses? Number 6. What are the venous connections of the cavernous sinus? Number 7. What are the types of cavernous sinus thrombosis? Number 8. What are the visual disturbances in cavernous sinus thrombosis? Number 9. How long antibiotics are given in CST? And number 10. Which nasal sinuses most commonly cause cavernous sinus thrombosis? Now let's do the cavernous sinus thrombosis. Cavernous sinus thrombosis is an acute life-threatening neurological emergency that occurs from number 1. Orbital cellulitis, number 2. Facial skin infections, and number 3. from sinusitis. Most common sinuses infection that cause CST are sphenoid and ethmoidal sinusitis. Which part of the facial infection most commonly causes CST? It's a triangular area with its apex at the upper nose between the two medial canthi and the base extending between the two corners of the upper lip. Where is cavernous sinus? Cavernous sinus is at the base of the brain on either side of sella turcica below the optic chiasma and running laterally to the temporal lobe and uncus. The two cavernous sinuses are in communication with each other through intercavernous sinuses, so the condition becomes bilateral. An important point is that cerebral veins and venous sinuses are valveless. They don't have valves, so the blood flows in either direction. Now, what are the cavernous sinus connections? These are the cavernous sinuses on either side with intercavernous sinuses joining the two cavernous sinuses. Anteriorly, they receive ophthalmic veins, superior and inferior ophthalmic veins, and facial vein also joins these ophthalmic veins, and posteriorly it's connected to the superior and inferior petrosal sinuses, and they are connected to the nasal, sphenoid and ethmoid sinuses via the small emissary veins. So emissary vein connecting sphenoid and ethmoid nasal sinuses to the cavernous sinus. Sphenoid and ethmoid sinuses are the most common site of primary septic CST. Number 4, they are connected to the meningeal veins, superior, middle and inferior cerebral veins, and basilar veins. What are the types of cavernous sinus thrombosis? It may be infective or non-infective CST. Non-infective CST occurs from number 1. dehydration, hypercoagulable state, and immunologic abnormalities. Number 2. vascular malformations, carotid artery aneurysms, and carotid cavernous fistula and meningioma may cause cavernous sinus thrombosis. And number 3. nasopharyngeal carcinoma can also cause non-infective cavernous sinus thrombosis, whereas infective cavernous sinus thrombosis occurs from Staph aureus and streptococci. Which organisms most commonly cause cavernous sinus thrombosis? 70% occur due to Staph aureus and 30% by aerobic or anaerobic streptococci. Now, contents of the cavernous sinus. They have in the lateral wall cranial nerve 3, oculomotor and 4 trochlear nerve, and ophthalmic and maxillary divisions of the trigeminal nerve. And in the substance, they have internal carotid artery and the 6th cranial nerve or abducent nerve. Involvement of all these nerves in the cavernous sinus thrombosis cause abnormalities of the eye and eye movements. Now, clinical features of the cavernous sinus thrombosis. Number 1. General features: fever, headache, neck rigidity, mental changes, and decreased sensation. Number 2. Eye disturbances: orbital pain, periorbital edema, exophthalmos, eye protrudes out, ptosis, conjunctival swelling, and lateral gaze palsy due to the involvement of the abducent nerve. 3/4 of the patients have unilateral periorbital edema, and that becomes bilateral because the two sinuses are interconnected. And number 3, visual disturbances in CST: increased intraocular pressure, papilledema, photophobia, decreased visual acuity, and visual loss. Dilated pupil due to the involvement of the oculomotor nerve and sympathetic plexus. Morbidity is high and mortality rate is 30% in cavernous sinus thrombosis. The lab investigations in cavernous sinus thrombosis: CT and MRI. CT scan visualizes thrombosis, but MRI better visualizes thrombosis. Definitive diagnosis is by cerebral angiography, and magnetic resonance venography also confirms the diagnosis. There may be dilated tortuous veins. Thrombophlebitis of the intracerebral and meningeal veins is suggested by the presence of intracerebral hemorrhages. Now the treatment of CST. Treatment of infective CST. Number 1, antibiotic therapy. Penicillinase resistant penicillins plus third generation cephalosporin. So penicillin resistance penicillin because of the staphylococcal infection, 70% of cases, and third generation cephalosporin. Vancomycin for MRSA, methicillin resistant Staph aureus. IV antibiotics are given for 6 weeks or until radiologic evidence of thrombosis resolution is present. Number 2, drainage of the abscess. Number 3, anticoagulation for primary thrombosis. Now treatment of the non-infective thrombosis. Number 1, anticoagulation with heparin. Number 2, catheter directed urokinase or recombinant tissue plasminogen activator RTPA plus IV heparin are given in non-infective cases of cavernous sinus thrombosis. And number 5, surgical repair for vascular malformations. Now answers to the questions: which part of the facial infection most commonly causes cavernous sinus thrombosis? As I already explained it, the disc triangular area marked with red dotted lines that has an apex between the two medial canthi and a base joining the two corners of the upper lip. Number 2, which infections cause cavernous sinus thrombosis? Number 1, orbital cellulitis. Number 2, facial skin infections. Or number 3, sinusitis from sphenoid or ethmoid sinusitis. These are the causes of infectious cavernous sinus thrombosis. Which infection causes rapidly developing blindness? Mucormycosis, a rapidly developing fungal infection, invades the retinal artery and causes sudden blindness in cavernous sinus thrombosis. Mucormycosis most commonly occurs in diabetes mellitus. CT and MRI in cavernous sinus thrombosis show opacification and destruction of the contagious bone. Question 4, where is cavernous sinus? We already discussed this, is at the base of the brain on either side of sella turcica, below the optic chiasma, running laterally to the temporal lobes and uncus. Question 5, in which direction blood flows in the sinuses? Cerebral veins and sinuses are valveless, so blood flows in either direction. What are the connections of the cavernous sinus? We already discussed earlier ophthalmic vein and the facial vein opening into the cavernous sinus here, and superior petrosal, inferior petrosal opening into the cavernous sinus, and they are connected to each other by intercavernous sinus, and they are also connected to the other meningeal and other cerebral veins, and they are connected to the nasal sinuses, sphenoid and ethmoid sinus via the emissary vein. Question 7, what are the types of cavernous sinus thrombosis? We already did it. Infective or non-infective cavernous sinus thrombosis, and the causes for the non-infective are dehydration, hypercoagulability states, immunologic abnormalities, vascular malformation, and nasopharyngeal carcinoma. Whereas infective type are called by Staph aureus in 70% of cases and by aerobic and anaerobic streptococci in 30% of cases. Question 9, how long antibiotics are given in CST? IV antibiotics for 6 weeks or until radiographic evidence of thrombus resolution is present. And the last question, number 10, which nasal sinus infections most commonly cause CST? Sphenoid and ethmoid sinuses are the most common sites of primary septic cavernous sinus thrombosis.